Good evening. Thank you for joining us for the Florida Society of Clinical Oncology Oncology Administrator webinar featuring our guest speaker, Rachael Willeford, ASCO's Senior Coverage and Reimbursement Specialist, discussing CMS Navigational codes. Before we begin this evening's webinar, I would like to remind attendees that your lines will be muted for the duration of the program. We do kindly ask that you utilize the Q&A chat feature if you have any questions that might be prompted throughout the presentation with Rachael. During the presentation, Rachael will either pause or use the end of the program to address those questions within the Q&A chat feature. Without further ado, it's my honor to introduce Rachael Willeford, the Senior Coverage and Reimbursement Specialist in ASCO's Care Delivery Department. Rachael is a certified hematology oncology coder with over a decade of oncology revenue experience in multiple practice settings. She acts as a main point of contact for billing and coding inquiries, in addition to producing oncology-focused educational resources for provider and practice support. Rachael also serves as the staff liaison to ASCO's Medical Association activities involving the CPT editorial panel and the RVS update committee. It is my sincere honor to welcome Rachael.
I appreciate everyone having me here. Today, we are going to discuss the CMS navigation codes. It's been a hot topic for a lot of people lately. So our first topic, our topics today in our discussion will first involve the code family that CMS has defined as services addressing health-related social needs. More frequently, we see these codes referred to as patient navigation codes or social determinants of health codes. And additionally, we will also cover the care management services family of codes. And finally, we will talk about reporting these codes and how these are reimbursed. So first, what are social determinants of health? We hear that a lot. Well, social determinants of health involve conditions of an individual's living, learning, and working environments that affect one's health risks and their outcomes. These have been recognized as important predictors in clinical care, and when these conditions improve, we see improved patient outcomes and along with reduced cost. So first, what everyone is wondering about, the services addressing health-related social needs, or more commonly, the patient navigation codes. So in 2024 final rule, the physician fee schedule final rule, CMS created a new family of codes that support activities encouraging the addressing and managing of social determinants of health. The result of this is 3 different services. They are community health integration, principal illness navigation, and then a social determinants of health risk assessment. The first of these services, community health integration, is initiated at an evaluation management visit, at which a problem is addressed and social determinants of health needs are identified that significantly limit the provider's ability to treat or diagnose the problem that was addressed. Certified and/or trained auxiliary personnel, which may include community health workers, then address social determinants of health needs in supportive activities that make up the community health integration services. Principal illness navigation being similar to that of community health integration, but these services focus on a serious high-risk illness. These services are also performed by auxiliary personnel whose certification or training also includes that revolving around the serious high-risk condition that requires the navigational services. These personnel may include cancer navigators, diabetes navigators, other care navigators, and even social workers, among others. Community health integration and principal illness navigation services include many of the same activities. So auxiliary personnel, when performing these activities, may communicate with all service providers. This would be regarding the patient's psychosocial requirements, their preferences, their desired outcomes. They may also assist with building self-advocacy skills and educating the patient on how to best participate in their medical decision-making. When this is involving principal illness navigation, this may also include providing the patient with information on participation in clinical trials. The personnel may also coordinate services and care transitions between all community and health-based providers and practices. They may also facilitate access to community-based social services as well as healthcare access. Social and emotional support may be involved to help the patient cope with the problem addressed, social determinants of health needs, daily routines, all in order to meet treatment goals. In addition to social and emotional support, staff may also provide mentorship and inspiration to the patient. And finally, an action plan may be established through a person-centered assessment within these services. One way that community health integration and principal illness navigation do differ is the role of facilitating access to care. Community health integration would facilitate, within community health integration, facilitation of access would be done. However, principal illness navigation, the auxiliary personnel may also refer the patient to applicable healthcare and community service needs in addition to facilitating access to care. The social determinants of health, risk assessment code G0136 is used to report the administration of a standardized evidence-based social determinants of health assessment tool. At a minimum, the tool that is utilized must assess the patient for 4 specific categories. Those would be food insecurity, housing insecurity, transportation needs, and utility difficulties. The tool may include other items that may affect compliance and the social needs of a patient, but at a minimum, it must assess for these 4 items to be able to report the code. Now, the intent for this code is not to screen all individuals. This is something to assess the patient, and it's meant to assess a patient with suspected or known social determinants of health needs. It is not a screening for all patients. In addition to specified training that may be required for auxiliary personnel, CMS has also instructed on certain criteria needed to report the codes themselves. So both community health integration and principal illness navigation require an initiating visit that is typically but not always limited to an E&M visit. And the medical necessity that would be required to be documented would be for the navigation services that were identified at the initiating visit. The social determinants of health risk assessment may be performed at or prior to an evaluation and management visit. Community health integration requires the identification of social determinants of health, since that's what is being addressed. And then principal illness navigation requires the identification of social determinants of health needs, or if there are any addressed, or if there are any present. Social determinants of health is not a requirement for principal illness navigation. If there are social determinants of health that are present at any of these services, the Z codes that are associated with those applicable needs should be reported and documented. The time spent furnishing activities must be documented in the record. With community health integration, that time would apply to time spent addressing social determinants of health. And with principal illness navigation, the documentation would be that of time spent in relationship to the serious high-risk illness. And then a description of the actual activities would also be required. Advance informed consent must be obtained and documented, and we will go more into that in a little bit more detail further along. But it should be advanced informed. And they should be informed of their cost sharing restrictions and rights. And it should be documented in the record. It's important to note that while these services may be performed by auxiliary personnel, with the exception of the social determinants of health risk assessment, they are reported by the billing physician or qualified healthcare professional. So all of these are reported by the billing provider, but they are performed. Community health integration, principal illness navigation are performed by auxiliary personnel. Social determinants of health risk assessment can be performed by either the clinician or the auxiliary personnel. Community health integration and principal illness navigation are performed incident to the professional services of the practitioner and are subject to general supervision guidelines. Next, care management. So care management services may also be a tool used to address social determinants of health by clinical providers and staff. Instead of an action plan, the practitioner would develop a comprehensive care plan in which social determinants of health are addressed if they are present. Care is coordinated within these services and managed by clinical staff or by providers for a serious high-risk illness or for social determinants of health. Many oncology practices provide care coordination due to the nature of the patients that are served within their practices. Many of these patients have multiple chronic conditions. There are 3 different care management services within the care management for patients who are at a significant risk of death or exacerbation or decline. These 3 are chronic care management, which require patients who have 2 or more chronic conditions expected to last at least 12 months. Complex chronic care management patients are also required that patients have 2 or more chronic conditions expected to last at least 12 months. But these patients also require a moderate or high level of medical decision-making and complexity within their care. Finally, principal care management requires that moderate to high complexity. However, these patients have 1 high-risk complex chronic condition expected to last at least 3 months. So the activities involved in care management are services performed personally by the clinician, or they are activities performed by clinical staff directed by and under the supervision of the physician or healthcare professional. So this may include developing a comprehensive care plan, managing the conditions. Obviously, the physician would be providing guidance and direction to clinical staff. You see there is education and medication reconciliation and management. So these are activities that are provided by the clinical and clinical staff and providers. So some of these activities seem to look very similar to that of navigational codes. While patient navigation requires an action plan, care management requires a comprehensive care plan. Care management may only be reported by physicians, qualified healthcare professionals, and clinical staff. So the activities included in these services are clinical in nature. Navigation codes, they're more focused on navigating the patient through care with support of the patient. Care management services are more focused on the management and facilitation of patients' care. Excuse me. So we hear talk of a comprehensive care plan. That's one of the required elements of care management is a comprehensive care plan. So what's included in that plan? While the list seen here is not all-inclusive, CMS and CPT both state that a comprehensive care plan typically includes the following items as they are appropriate for the individual being seen. Items like a problem list, their treatment goals, what is the anticipated outcome and prognosis? What are we managing? Are the symptoms being managed, medication being managed? What community and social services are needed for this patient? Who's coordinating the care and what care is involved? How often are we reviewing this? In addition to these outlined items, the Institute of Medicine has a more detailed 13-point care plan that is used by some care models as a reference. Excuse me. In addition to the individual clinical activities that are being performed through care management, there's also additional practice requirements that are outlined by CPT as part of care management services. So patients should expect to have 24/7 access to care, access to physicians and other qualified healthcare professionals. There should be a designated member of the care team to provide continuous care, and the patient should expect to have timely access and management for follow-ups. The care team should have timely access to clinical information through an EHR. And there should be coordination amongst all service professionals. Finally, a physician or qualified healthcare professional should oversee the activities of the care team. So CMS has also provided similar actions that are expected out of a practice. So patient consent is absolutely required. That includes cost sharing, the ability to terminate services, the fact that only one practitioner per month can report the chronic care management and complex chronic care management services. A designated care team lead should be assigned. That's going to ensure continuity of care and also act as a point of contact for that patient. The care plan should be established, implemented, revised, and monitored. This isn't just something that gets put into place one time. It's continuously looked at and reviewed and updated. And then the data should be recorded in the electronic health record. So when implementing these services for care management, the following steps would be looked at to be considered. You're going to establish a workflow. How is this going to look in your practice? The care management process would be defined. Who is taking place in which roles? Like what staff is going to provide which roles? You're going to prepare the practice and the EHR and your billing service for reimbursement. The codes need to be put in, and there's got to be some way for this to be captured. Then ongoing monitoring and quality improvement must be established. Again, it's not a one and done kind of thing. A lot of these patients are chronic. Well, by definition, these patients are chronic. So this is going to be something that is ongoing. And then look for opportunities with commercial payers. See which ones are reimbursing for this. Again, just a reminder that payers, just because there's a CPT code, they don't have to reimburse for something. They have their own policies. And then look at digital tools to leverage services. Documentation requirements for care management include recording the need for the care management services. Why do they need these services? What's the condition that is requiring these services? The beneficiary needs to be eligible. There needs to be a recorded care plan that is being monitored and reviewed. The patient and caregiver must be given a copy of the care plan. They need to know what to expect. Also, a discussion It has to be done with involving consent and recorded either verbally or written. And then you should also document what services were rendered and also the time spent on those services. Getting into reporting. So there are some things that are kind of universal. Time requirements. All of these services, with the exception of the risk assessment tool, is by calendar month. The time for each service is the total time for the calendar month, not a specific date when these services were rendered. So you're going to compile this over the calendar month. Time requirements must be met or exceed that in the code description. And the date of service for the billed charges would be the date in which the time requirement is reached. That's what would be reported. So consent, that we said we would talk about it some more. So it's advanced informed consent that's either written or verbal that has to be documented in the patient's medical record, and it's got to be done before performing these services. Care management requires that consent involve acknowledging the availability of the care management services, cost sharing, and that only one practitioner can bill the chronic care management and the complex chronic care management during a calendar month. Consent's only required once per patient unless they switch to a different practitioner. Now, patient navigation is a little bit different. Obviously, cost sharing, the patient's got to know about the cost sharing obligation of these services. Community health integration can only be billed by one practitioner. And the patient, again, needs to know that they can stop these services at any time. This is to be done once for community health integration and annually for principal illness navigation. Social determinants of health risk assessment doesn't require consent per CMS. So there's no outright requirement for that. Specifics for documentation, starting with patient navigation services. So looking at the codes themselves, so community health integration, think about social determinants of health needs. And then for principal illness navigation, it's going to be that serious high-risk condition. Again, expected to last at least 3 months, and they're at significant risk. And then the social determinants of health risk assessment, while being revolving around social determinants of health, it's the actual administration of an assessment tool. That assessment tool must be standardized and evidence-based. CMS gives several examples of these tools. For community health integration and principal illness navigation, episode of care is going to be per calendar month. Social determinants of health risk assessment will be every 6 months. So what are the codes themselves? So community health integration will be reported with a G0019 for the first 60 minutes per calendar month, and G0022 will be for each additional 30 minutes. Principal illness navigation, very similar. The first 60 minutes is going to be G0023, and G0024 will be each additional 30 minutes. For the add-on codes, there is no frequency limit that has been established yet. Now, there are 2 additional codes under principal illness navigation. They are for peer support specialists. This is a G0140 and G0146, similar setup with first 60 minutes and each additional 30, but they are limited to behavioral health conditions only. Finally, you have your social determinants of health risk assessment as reported with a G0136 for 5 to 15 minutes of time. It's kind of like counseling time, but this is for that risk assessment tool. Concurrent services for our navigation. So this could be reported, our patient navigation services could be reported with advanced advanced care planning or management, behavioral health integration, chronic care management, so your care managements, principal care management, and transitional care managements. But what is a concurrent service? So it's services that require separate time and effort. So the billing requirements for both the navigation services and these that are concurrent services would be separate. They are met separately. They don't overlap. And of course, the services must be medically reasonable and necessary. The initiating visits required for each. So both a community health integration and principal illness navigation could be initiated with either an E&M visit or an annual wellness visit. But principal illness navigation have a few more that allow for initiation. So your E&M visit, that's part of transitional care management, could also qualify, along with psychiatric diagnostic evaluations and health behavioral assessments and interventions. Social determinants of health doesn't outright require an initiating visit, but usually it's performed either within an evaluation and management visit or prior to that visit. And again, it's not a screening tool. It's not like a screening. There's got to be some kind of discussion, and the physician or qualified healthcare professional is assessing that patient for these social determinants of health. CMS has adopted similar restrictions for the navigational codes as we see for that of the care management codes. So like chronic and complex care management that we will talk about, community health integration services can only be reported by one clinician per beneficiary per calendar month. So it's really on the patient and the provider, and that's why you have to let the patients know up front that this can only be reported once per clinician and beneficiary. Principal illness navigation restrictions are similar to that of principal care management. So more than one clinician per beneficiary can report this if the services that are being provided are related to different conditions. And then finally, the social determinants of health risk assessment is once per beneficiary per clinician. So they don't really say that it can or cannot be performed, but it's once per beneficiary per clinician per 6-month period. So multiple clinicians possibly could be reporting this. So when you're looking at the services and you're determining what code to report, think the main things to keep in mind when selecting those codes is the reason for the service. Are the activities addressing social determinants of health, or is there a serious chronic illness or condition that's affecting the patient? Who's providing the service? Is it clinical staff, a provider, or is it auxiliary staff member who has an agreement or is employed by the practice? Because that's important. Auxiliary personnel must represent a expense to the practice. They have to either be employed, a leased employee, or contracted by the practice. And finally, how much time was spent providing the service? Were time requirements for the codes met? So we have our example here. Our patient currently has breast cancer and is receiving chemotherapy every 2 weeks. So the patient came in, discussed the treatment plan with the physician, and it was revealed that the patient shares the family vehicle with their spouse, who can't take off work to bring the patient to treatment. So now the family is financially strained. In addition, the family is financially strained due to financial obligations related to the diagnosis, and the patient tells the physician the stress is affecting their marriage. So through this, the patient is engaging a patient navigator to address issues that were uncovered at the E&M visit and is working through services to help this patient. So an appropriate evaluation and management code along with a social determinants of health risk assessment code may be reported for the activities at that evaluation and management. And after the engagement with navigation, the navigator is working and identifying transportation, financial assistance, and connects the patient and their spouse to local emotional support programs that are available within the community. So for the first 60 minutes that the navigator provided, the billing provider would bill a G0136. Sorry, not a G0136, it's a G0023 for the first 60 minutes. And then if they have additional 30 minutes, they reach additional 30 minutes, they would be able to bill a G0024 for the additional 30 minutes for navigation. Moving along to care management services and what this looks like. So chronic and complex care management both require 2 or more chronic conditions expected to last at least 12 months. And then principal care management requires 1 complex condition expected to last at least 3 months. Service time for all of these is calendar month. They all require significant risk of death, acute exacerbation and decompensation, or functional decline. All require a comprehensive care plan. Complex chronic care and principal care management both require moderate to high complexity. Chronic care management is billed with a 99491 for the first 30 minutes and a 99437 for each additional 30 minutes. And this is if it is activities reported by the physician or qualified healthcare professional. If it is provided by the staff, it would be a 99490 and a 99439 for the first 20 minutes and each additional 20 minutes. Those add-on codes are limited to 2 times per month. Principal care management, I'm going to drop down to principal care management, is reported for physician and qualified healthcare professional activities. That is reported with a 99424 for the first 30 and a 99425 for each additional 30. If it's clinical staff, that would be a 99426 and a 99427. Again, those add-on codes are limited to 2 times per month. Complex chronic care management is a little different in that there is no code to report physician or qualified healthcare professional time. You would report clinical staff time of first 60 minutes with a 99487 and each additional 30 with a 99489. However, the physician or qualified healthcare professional that is seeing the patient, is managing their care, and creating the care plan, they must still provide direction to that clinical staff. And any time spent on any activities or time that is personally performed by the physician or qualified healthcare professional may count towards clinical staff time and be reported as such. So activities that don't count towards the time, so they are separate. So you can't count time of services from telephone E&M visits, online digital E&M, prolonged E&M services, unless it's different from the E&M. Those all have to be reported with the actual code themselves. Medication therapy management, if it's spent by a pharmacist, that goes towards medication therapy management. These are not included in care management. Requirements of clinician restrictions. Like we said, chronic and complex care management services only one clinician per beneficiary. Again, part of consent is that our patients are notified that only one clinician per beneficiary per calendar month can report this so that they can help. Hey, I'm already being monitored, or I'm already under care management services by physician X. So physician Y can't bill it. But this is also part of the reason why care coordination is so important, is so that, hey, if physician X's office is coordinating care, then perhaps physician Y should be kept in the loop, and so forth. Principal care management services may be reported by more than one clinician if there's an exacerbation in more than one complex chronic condition. So if there's an exacerbation, let's say the patient has both diabetes and cancer, and there's exacerbation in both, then yes, those both both physicians who are monitoring each of those can report that. Initiating visits for chronic care management requires that there be an initiating visit either to each new patient or patients who are not seen within 1 year prior to starting of the service. And it requires either an annual wellness visit, the initial preventative physician exam that is allowed by Medicare, or by an appropriate E&M visit. So what are we going to think of when we're looking at code selection for care management? Well, how many conditions are being managed? Is it 2? Is it 1 serious high-risk illness? Is it what's going on? How long is the condition expected to last? This has got to be expected to last a significant amount of time. Who's providing the service? Is it clinical staff? Is it a physician? Is it auxiliary personnel? What's going on? And were the time requirements for the codes met? So in our example here, we have a patient who was diagnosed with colon cancer and is undergoing biweekly chemotherapy. Their treatment is causing significant nausea and vomiting as side effects. And because of reduced work hours, the patient's having a hard time with medical bills. So the physician talks to clinical staff within their practice to assist the patient to ensure that the patient adheres to treatment. So in this example, clinical staff is going to coordinate with a nutritionist because of the nausea and vomiting to ensure that the patient has adequate caloric intake during treatment. And the nurse may also assist with enrollment applications for assistance programs due to financial issues. So the activities will be reported with an appropriate E&M code for the initial visit and potentially a prolonged service code. Principal care management code 99426 after completing 30 minutes of service by staff, and then a 99427 for if an additional 30 minutes had been obtained by the end of the calendar month. And then when the physician discusses progress on the social determinants of health needs at their follow-up, this could either be counted for either an E&M or the Principal Care Management Code. However, it can't be reported for both of them. Time has to be separate. Also, any ICD-10 codes that would identify psychosocial needs in this would also be reported within the patient's medical record. So reimbursement, what does reimbursement look like for these services? So first, community health integration, the G0019 is going to be reimbursed at $80.56, and we'll have an RVU of 2.42. The G0022, which is for the add-on code, each additional 30 minutes, is reimbursed at $50.26. it has an assigned RVU of 1.51. So these reimbursements will reflect national amounts for the non-facility setting. Of course, your actual amounts will vary by location and municipality. And then cost sharing does apply to these codes. So principal illness navigation, G0023, they are very so the principal illness navigation services are very similar. They are set up, have very similar framework as that of community health integration. So you see similar, very, very similar reimbursement rates. So the G0023 is also at $80.56. G0024 is also at $50.26 and have the same RVU rates as the community health integration. Social determinants of health risk assessment is reported with the G0136, again, 5 to 15 minutes once per 6 months, and it is reimbursed at $18.97. Its assigned RVU value is 0.57. Looking at how they compare, community care management for staff is the first 20 minutes would be reimbursed for $62.58 with an assigned RVU of 1.88. And then the add-on of each additional 20 would be reported with 99439. It's reimbursed at $47.93 and is assigned an RV value of 1.44. Practitioner time, say your physicians and qualified healthcare professionals, their first 30 minutes will be reimbursed at $84.55 or with an RVU value of 2.54. And that add-on code will be reimbursed at $59.59 with an RVU value of 1.79. So a little bit higher than your staff, but you can see how it kind of compares to your community health integration. Complex chronic care. So this is going to be your complex conditions that are going to last at least 12 months, requires complexity. For staff, it's going to be reimbursed, and it's only reimbursed for staff. The primary code, the 99487, for 60 minutes would be reimbursed at $134.15 with an applicable RVU of 4.03. And then that add-on code for each additional 30 is reimbursed at $72.23 each with 2.17 RVU. Principal care management, which is comparable to the activities or comparable to principal illness navigation. Staff time is reimbursed at $61.92 for the first 30 minutes and then $47.27 for each additional 30. It is 1.86 and 1.42 for RVU value. And then for principal care management provided by practitioners, 99424 is $82.55 for that first 30 minutes. And then each additional, the add-on code is $59.92, 2.48 and 1.80 for your RVUs for that. So care management services, transitional care management, and the social determinants services. So your principal navigation, community health integration, and the risk assessment, those all include activities. They all have activities that are included in the enhanced services or the participant redesign activities within CMS's enhanced oncology model. So enhanced services are paid as part of the monthly enhanced oncology services payment of the EOM and are not separately reimbursable outside of the EOM program for applicable patients and their participants. So it's just something to consider when looking at implementing these services. So resources that are available and that we also have used. So CMS has a lot of resources out there. CMS actually has a care management services landing page where it goes into advanced care planning, care management, transitional care management. CMS also has a health-related social needs FAQ article FAQ article that came out this spring. That updated guidance that was given in the final rule. They also have health equity services. It's an MLN article about health equity services in the 2024 physician fee schedule final rule, as well as updated information about using the social determinants of health risk assessment in the annual wellness visit. And then you have the 2024 final rule. ASCO also has a care management services resource that goes into implementation, consideration, practice, information about care management. But we also have a comparison resource that takes the care management services and patient navigation services and compares them regarding definitions, requirements, documentation, activities. It goes into a deep dive in these care code families. You may be thinking, how do I find them? So ASCO on their webpage has a coding and reimbursement webpage out there with free resources. Available resources include an updated coding tip of the month. We also have timely updates for HCPCS, ICD-10, and CPT updates. We also have evaluation and management information in regards to updates for the 2021 and 2023 changes. We also have additional practice administration guides and brief coding resources out there as well. So if you're interested, you can go to asco.org, drop down in the patient practice and patients tab, and you can go under billing, coding, and reporting, drop down to coding and reimbursement. You'll find a whole web page of coding and reimbursement resources. We also have a Medicare program page that has additional information that you may find helpful. Questions about this presentation material or any other coding questions may also be sent to practice@asco.org. You get a certified coding professional who can answer questions there. But are there any questions at this time that I can try to answer for you?
Rachel, it looks like two questions came in through the Q&A chat feature. Are you able to see those?
I can try to see them now.
Okay.
Does the initiating visit have to be in person or can it be virtually? So the community health integration and principal illness navigation are not on the telehealth list, but there is documentation about virtual components. I would have to look at it specifically, and if they want to email, I can get that back to them. I don't want to tell them the wrong answer, and I would rather be able to look at it for you. And then for the PIN codes, can you build them in the facility setting in a hospital-based cancer center? So the FAQ that was set out this spring does say that both community health integration and principal illness navigation can be billed either in the facility or non-facility setting. So yes, you can build them in a hospital-based practice. And then I can certainly send the slide deck to Amanda and Kelly. That is not an issue. But again, all this information is also available free on our website. For principal management codes, does the provider and the nurse navigator submit codes? So it would be or. I would have to look. I'm pretty certain it's one or the other. It's not both. If there's time, you could, if the physician, it's kind of like with complex care management. If there's one, then it can be considered for the other. But Mary, I can get you something that tells you that specifically.
Wonderful. Does anyone else have any additional questions that they want to ask in the Q&A chat feature?
These are good questions.
Yes, they are. We
Look,
love
and
an engaged audience.
questions help us. It's
That's right.
what's the information that y'all are looking for? Is there information that we didn't disclose that y'all are needing? It's always helpful.
Wonderful. So it looks like that will wrap up our program. I would like to thank Rachael for joining us today and ASCO for sharing this information with us. We sincerely appreciate you sharing your time and your knowledge. I definitely look forward to following up with each of the attendees with this slide deck. And if anyone has any additional questions that I can reach out to Rachael on their behalf, I'll be happy to do that post-program. I would love the opportunity to also take a time to share that FLASCO does have an administrator network. It is a group of administrators that basically come together and share support, ideas, education. This is kind of one of those efforts as an extension to the admin network with this sort of platform here with Rachael today. In addition, during our upcoming fall session in November, we will host our own administrator track during that session. That'll be November 1st and 2nd in Orlando, Florida. It's a wonderful program offered free to FLASCO members. As an oncology administrator, you apply for free membership. So again, that's a great opportunity to connect with other administrators, to hear discussions very similar to this, excuse me. It's an entire day of educational tracks just for administrators. So I will be happy to provide that information in a follow-up. And again, Rachael, thank you so much for your time today. This program was recorded, so it will be available following the program for those who would like additional information or perhaps would like to share this with their colleagues. Again, I appreciate you all for joining us and look forward to hosting another Administrator Network webinar soon. Have a great night.